Hello, my name is Simon Marsh and I'm one of the consultants here at 108 Harley Street. Founded in 1991 by the late Jerry Gilmore, 108 Harley Street is a fully independent multidisciplinary practice with consultants in a variety of specialties, and you can see the clinics we run across the bottom of the slides. So I'm part of the London Breast Clinic team, but I also lead the Gilmore Groin and Hernia Clinic, and I work with my colleagues in the Skin Clinic and in the Sports Injury Clinic as well. Now, we're aware that obviously times are changing and the way that we interact with our fellow professionals is also changing. As part of our continuing commitment to medical education and to help maintain effective communication not only with our GP colleagues, but also with physiotherapists and other allied health professionals, we're embarking on a variety of short presentations that reflect the services that we offer here at 108 Harley Street, including but not limited to breast problems, hernias, Gilmore's groin, vascular surgery, dermatology, gynecology, and so on. And we're going to deliver these as a series of live lunchtime events, but we'll also make them available on the website so people can view them at their leisure. And our aim in these short talks is to cover one topic in around 12 slides, about 20 minutes. And we're going to try and make these 108 Harley Street CPD snippets easily digestible, not too onerous, and maybe even a little entertaining. Now, if you have suggestions for topics you'd like us to cover in future, you can see the email address at the bottom of the slide, symposiums@108harleystreet.co.uk. So get in touch and we'll try and cover any topics that you think would be helpful. Within each presentation, there's going to be one or two key slides, and you can see the key motif in the top left-hand corner of this slide. So these are the real learning points to look out for from each talk and things to take away. So I thought I would start by looking at some of the common breast lumps that we see. So we're all taught the first thing you do when anybody comes to you with a problem is you take a history, because we're told, and I'm sure you remember, that you make a diagnosis on the history 80% of the time. Now, actually, that's a really interesting figure, and it dates back to a paper by Hampton in 1975 in the British Medical Journal, where he looked at referrals from GPs to specialists, and the specialist would make a diagnosis based on the GP letter, and then after they'd taken a history, and then after they'd read the letter and taken a history and done an examination. And it does turn out that the combination of the GP letter and the history means you can make a diagnosis in 80% of the time. If you just take the letter on its own, you get it right 50% of the time. And that actually fits very closely with a paper I published in the mid-90s looking at referrals to a breast clinic, where what we found in the days when GPs would write a nice letter to a named consultant with all the information in it, that when the GPs found a lump and described it and said, we're worried this might be cancer, they were right 50% of the time. Now, I think that's pretty good. Really reassuringly, when the GPs write and say it's not cancer, they were right 99.9% of the time. And that 0.1% was a very small number of cancers we picked up incidentally on mammograms that were too small to feel. So in the days when you can write your history and examination and give a possible diagnosis, you get it right more than half the time, and I think that's really good communication. Now, what you have to be aware of when you take a history from a patient is that to patients, different things may mean different things to how we see it. So when they say they've got a lump, it may not actually be a lump, but the things you're looking for are, is there a definite lump? Is the breast just nodular? Does it hurt? And you've got to look at nipple changes and so on. And you've got to look and ask about any lumps in the armpit, redness, inflammation. And you're supposed to ask with breast problems about the family history and menstrual history and breastfeeding history and so on. And while those may give you an indication of breast cancer risk, and that may be something we cover in a future 108 CPD snippet, it doesn't necessarily help you on the day at working out what things are. But it is right that a proper history will give you the diagnosis in 80% of the time, so we mustn't ignore that. And then you're supposed to examine. The first part of examination is inspection. And you look at size and symmetry, and I've got a slide here of beautifully symmetrical breasts, but most ladies are not symmetrical. Most ladies have one breast slightly bigger than the other, and most ladies have more gland tissue on one side than the other, and we'll come to that on the examination in a minute. But again, you're supposed to look for skin changes and puckering and this peau d'orange, which is supposed to be a sign of edema in the breast with a cancer underneath it, but you can get similar changes in benign conditions as well. and look for discoloration, ulceration, and you're supposed to examine for nipple changes, look under the arms and themselves and in the neck. So all those things you're supposed to do, because that all helps with the communication at telling us what might be going on. Now, palpation actually is really difficult, and it's relatively more straightforward when you've been doing it 30 years, but it's not actually easy. This is a slide that Breast Cancer UK put in the Sunday Times magazine a few years ago about the different way breasts can feel, and it's not particularly straightforward. Now, to help you, and the way I explain it to ladies is that there are two things in the breast. There's gland tissue and fatty tissue, and the bottom half of the breast, even in slim ladies, is mostly fatty tissue, so it's always softer. And most of the gland tissue is towards the upper outer part of the breast. And this is where the packet of frozen peas comes in, because that is what normal knobbly gland tissue feels like in a lady. And I'd love to say this was my own idea, but it wasn't. When I was doing my molecular biology research into the cause of breast cancer at midnight at Charing Cross, I also ran the breast screening clinic at the time. And I remember saying to a lady, I just need to examine and see if I can feel anything. And she just said, that's easy for you to say, but it feels like a packet of frozen peas to me. Now, I can't remember her name, so I'm afraid I've called it the Marsh packet frozen peas syndrome. And obviously I would use Waitrose frozen peas. Now, interestingly, when I come to do teaching sessions and try and teach students about breast lumps, and I'm sure you know, you can buy these models that have lumps in them, and I have to say they're all pretty terrible. And what I've discovered is the best way to make a model of the breast is to take one of these, they're called comfies, you can see it in the middle there. And these are sort of prostheses that ladies wear after they've had a mastectomy, before the scar has settled down, when it can still be a bit sore. And these are stuffed with cotton wool type material, and you can take out the cotton wool type material from the top, you leave it in the bottom where the fatty tissue is, where it's softer. And in fact, frozen sweet corn is actually slightly better than frozen peas, and you can put that in the top half. And within that, you can put various nuts to represent various lumps. So you might have a macadamia nut, which is fairly smooth. There might be a cyst. You might have a hazelnut for fibroadenoma, or you might use a walnut or Brazil nut to represent a cancer. And you can put them near the surface and deeper down. And you can see sometimes it's very difficult to feel. So for example, if you've got a cyst, it might be a macadamia nut deep down in the breast, you've got all the frozen sweet corn over the top, so it feels quite nodular. So it can be sometimes very difficult to tell. The only trick we do in teaching sessions like this is you've got to get on with it, because otherwise the sweet corn defrosts and then it really isn't so good. But think about the knobbliness of the packet of frozen peas. Now, stick with that analogy just for a second as well, because when you take frozen peas out of your freezer, they clump, and breast tissue begins to do this. We'll come back to that, particularly in the mid-30s, you get clumps of gland tissue. And that's a normal change, but it's a new change as you get into the 30s. So that's how to think about examining the breast. So the key things on examination, if you're looking for a lump, is breasts are either normal, or you've got this diffuse nodularity, the packet of frozen peas or sweet corn feeling, or you've got the clump of frozen peas, which we will call focal nodularity, or you've got a definite lump. And that's really all you're looking for. And you can express it in one of those ways. Now, if you've got a definite lump, you've got to describe it. I was lucky enough, or perhaps unlucky enough, to be examined in my finals in Cambridge more years ago than I care to remember, by Sir Norman Browse, who wrote Symptoms and Signs of Surgical Disease, which is still a brilliant book on how to take a history and examine people. And these are all the things that he said that you must elicit and describe when you find a lump. So if you find a breast lump, the first thing you want to know is where it is. Now, classically, the breast is divided into 4 quadrants, so upper outer, upper inner, lower outer, lower inner, and then you've got the retroareolar area as well. Now, unfortunately, I complicate that by adding an upper centre, an outer centre, an inner centre, lower centre. So that sort of gives you 9 bits across the breast and 1 in the middle, but that helps you localise where it is. Obviously, you look, is there any redness or inflammation over the top? Is that colour change that might suggest an abscess or infection? Does it feel warm, again suggesting infection? Is it tender? Because in general, and ladies know this, if it hurts, it's probably all right. Not always the case. I saw a lady in her 60s last week with a very tender lump in her right breast that turned out to be a cancer. So it's not always the case, but usually if it hurts, it's a good sign. And then the size, and we'll come back to that in a minute. And then you've got to think about the shape. Is it ovoid? Is it irregular? Is it spherical, and so on? And then Sir Norman tells us you've got to describe the surface. So is it smooth or irregular? You've got to describe the edge. Is that irregular or smooth? Then you've got to think about the composition. So is it solid, liquid, might it have gas in it? And then talk about the consistency. And he described it's either stony hard, rubbery firm, spongy or soft. And you think about it in those 4 ways. And if you keep to a limited number of ways, it becomes much easier to examine. And yes, okay, you can say cancers might be stony hard, but some cysts can feel quite firm. So it's not always easy to work out what it is, but if you describe it, you're well on the way. And of course, you should examine, if you're worried about a breast cancer, the lymph nodes under the arm and the neck. List on the right, we're not really so worried about in terms of breast lumps. I suppose the bottom 1 or 2 relation to surrounding structures. So is it fixed? It's not common to come across fixed breast cancer anymore because we picked them up earlier, but occasionally you find a fixed lump. And you might want to relate it to the state of the local tissue, see how deep it is, or perhaps it's invading the skin and so on. So those are all the things to think about if you find a lump. And again, it's all about getting the communication over. Now, in terms of measurement, medicine and surgery in particular has this great thing about vegetables and common household items about how you describe the size of things. So we get things referred as a small bean or a small plum or a nut indeed. And I once had a lovely few weeks light-hearted correspondence with one of my GP colleagues because he referred a lady in with a lump that was the size of a small golf ball. And I wrote back and pointed out there is no such thing because a golf ball is always 42.67 millimeters across. You cannot have a small golf ball. You can actually have a small squash ball or a small tennis ball by a millimeter or 2, but you can't have a small golf ball. And we had quite a few entertaining letters back and forth discussing how you describe things. So the easy way to, of course, is just to measure things. And then we know exactly what it is. My wife tells me, and she's a GP, that women are very good at getting measurements. Men obviously not quite so good. So I have calipers and tape measures, and I will measure things, and that's really helpful. And when I do sometimes get frustrated with some of my colleagues at work, because we'll occasionally have ladies who have breast cancers who are not fit for surgery, and we treat them with the endocrine treatment alone and hope the lump shrinks. And because of the way things run, particularly in the NHS, continuity of care is not as good as it was, and sometimes they'll see somebody else before they come back and see me, and I haven't seen them for a while. And you go back through the letters and it says it's about the same size, or it doesn't seem any smaller. And you think, oh, please measure it, and I know exactly how big it is, and we can tell whether the endocrine treatment is still working or not. So measure it, and that gives us the right size. And again, it's all part of this, and this is the thing that I think I value probably as much as anything, and particularly in private practice, where we can still write letters to each other, and we can still do named referrals rather than these dear doctor generic things. And all of these things are just so much better than the situation in the NHS, I'm sure you're aware of, where if you make referral to a breast clinic, you have to use these awful tick box forms. And where I work in the NHS, the form gives you 2 choices. You can tick cancer, or you can tick something that they call exhibited breast symptoms. I have no idea what that means. And these forms have box and box and page of all the demographic details about the person you're wanting to see, but almost no space to put in what you think the lump is, what you've found, what the clinical findings are, and so on. And I just think that detracts from the relationship between doctors, and it's something we should fight to keep. Communication between us is vitally important in looking after our patients properly, and you can tell that means a lot to me. So once you've got a history, an examination, and you found a definite lump, these are the sorts of things you're going to think about, and we'll just run through these and say a brief word about each one. So as I've said, this packet of frozen peas clump, this focal benign breast change, is probably one of the most common things you'll come across. And ladies will come and say, I've got a lump, when in fact it's not definitely a lump, but it's a focal knobbly bit. And it's often tender, and it's often in the upper outer part of the breast, and it's usually in ladies as they get into mid-30s. This is when it becomes most common. And then we get into cysts, which is usually round, smooth, mobile, occasionally tender. You might find they're a bit compressible if they're not full, and sometimes you get cysts that feel a bit like a half-full hot water bottle, but some of them are really tense and you can't compress them. Sometimes they can be a bit inflamed to get redness over the top. Very rare to get a truly infected cyst, but it can happen, but usually a bit inflamed. And then we've got the fibroadenomas, tend to be in the younger ladies. Again, these are described as, you'll remember old-fashionedly, as a breast mouse. They tend to be very mobile and smooth. And I've lumped in with these the phyllodes, or you can put an I in there if you like and call it phylloides tumours. Now, I've never diagnosed one of these on examination because they feel like fibroadenomas, usually. So on a biopsy, you might get back from the pathologist, it looks like a phyllodes tumour, and those we would remove. Very occasionally, you get truly malignant phyllodes tumours. These are really odd, and I've only ever seen a couple, but they're really strange, but very rare. And then you come to what everybody worries about, which is breast cancer. And again, it might be a firmer lump, irregular, it might be fixed or not, but it's not going to be as mobile. And then we get adenomas, which are a bit like fibroadenomas, but without the fibrous bit. We see this occasionally in ladies who are breastfeeding. You can get lactating adenomas. And a few years ago, I removed, well, I think it's probably the largest one in the literature. It was about 20 centimetres. And a lady who had to have her cesarean section for her baby and then come back to theatre the same night so I could take her lactating adenoma out. And I can't find one bigger in the literature. But they can be very big. They can also be smaller, and you can see them in older ladies, and they erode through the nipples, so they can look really like it might be a breast cancer. But they turn out to be benign adenomas. It doesn't mean you need to remove them, because often you find ladies, they just bleed from them, so they need removing, but they're benign. And then there's other benign condition called fat necrosis, I'm sure you've heard about. Typically, this is a seatbelt injury, and you have a lady who's been in a car crash, and she gets very bruised from the seatbelt, and then as the bruising goes down, you end up with a lump. When you examine it, it feels quite hard, and when you take a mammogram, it looks like a breast cancer. And the secret here is the bruising, because you will occasionally get ladies who come along and say, I knocked my breast and now I've got a lump. And I will say, well, how much bruising did you have? And they'll say, well, none. And in that case, they've probably always had the lump, but the trauma has just brought their attention to it. In fat necrosis, there's a lot of bruising, the bruising goes down, then they feel the lump, and then the lump goes away, but you still have to biopsy to prove it, and it can take many months for the lump to go away. I think you can also get spontaneous fat necrosis in very large breasted ladies. So I occasionally see ladies with fat necrosis and they say, I really haven't banged myself, but they do get fat necrosis. I think that's in the larger breasted ladies. Galactose or milk cyst, obviously in breastfeeding or pregnant ladies, you can drain them, they tend to go away by themselves. You try not to do core biopsies of these because then you get a milk fistula where you get a little hole in the breast and the milk just leaks out. So try very hard not to core biopsy those. Periodontal mastitis and breastfeeding mastitis and abscess I will cover in a talk coming up soon on mastitis. So we're going to leave those. Duct papillomas usually present as nipple discharge, and again I'm going to cover nipple discharge as well later on, but sometimes you can feel them. And similarly, this rare benign condition called granulomatous mastitis I'll cover in the mastitis talk. I'll say a little bit about what I call Mondor's condition, but is often called Mondor's disease. And it's not really a lump, but it's superficial thrombophlebitis of a vein in the breast, usually laterally running vertically, and ladies come along with this tender cord. And often they can see it, and sometimes there's a dip in the breast as well. And we don't know why it happens, it's harmless, gets better on its own, but the trick is to know it exists and to recognise it. And then as with anywhere else in the breast, you can get any other lumps that occur in the skin. So you can get lipomas and epidermal cysts. And inflamed epidermal cysts will often leave a sort of discoloration in the skin, a sort of brownish discoloration that never goes away. So look out for that as well, very common in the inframammary crease. And I've seen TB of the breast. I've seen ladies presenting with a lump in the breast that turns out to be lymphoma. And obviously we're interested in lymphadenopathy. Most lymphadenopathy we see is harmless. It's very common to feel normal lymph glands in slim, healthy ladies. People with arthritis will get dermatopathic lymphadenopathy, and we also see it in ladies who've got tattoos, and often when you biopsy those you can see tattoo pigment in the lymph node, and in ladies who've got implants they will often get reactive lymphadenopathy, and quite commonly you'll see silicon adenosis, it's called, where the silicon leaks out of the implant that may not have ruptured, but it still leaks out and gives you enlarged lymph glands. So that just gives you a feeling of all the things that we're looking for, and what you need is this graph here, because this really tells you about the 4 commonest situations you're going to come across and the ages which they occur. And as we've mentioned, fibroadenomas tend to be in younger ladies. You will occasionally pick them up in ladies of breastfeeding age group on mammograms, but they probably always had them. And then you've got the cysts that come in a bit later on, ladies in their 40s and 50s is very common, and covering the whole age group there is this diffuse or focal nodular Rosen-Pease syndrome, as I call it, very common. And obviously cancers get more common as you get older, but any of these can occur at any age, which is why when you think about breast lumps, yes, you think about the age, but also think about your clinical findings. because you might find in a 35-year-old lady a stony hard irregular lump that doesn't seem to move, and even though she's 35, that's more likely to be a cancer than a round smooth oval lump that's likely to be a cyst perhaps in an older lady. So your clinical findings are really important, and that list of Sir Norman Brown's is really important, but put that all together, the age and the clinical findings, and then think about that list of potential or likely diagnosis, and then you write that with us and we will, between us, sort out what we get. So it's that effective communication that's really important.